going to introduce our speaker today. Her name is Christina LaMaire. She's a board certified cancer genetic counselor at the Icahn School of Medicine at Mount Sinai. She provides risk assessment and genetic counseling services to individuals concerned about hereditary cancer risks, both at Mount Sinai's Cancer Genetic Counseling Program and at the Dubin Breast Center. She holds a Master of Science Genetic Counseling from the Icahn School of Medicine at Mount Sinai and a Bachelor of Science in Genetics from North Carolina State University. I'm happy to turn it over to Christina to talk to you about this important topic. Thank you so much.
Yeah, hi everyone, and thank you so much for the introduction, Erin, and the invitation, and thank you to everyone who's taken the time to join this lecture. I'm really looking forward to speaking today more about cancer and inherited risk, the role of cancer genetic testing and counseling, and whether this is something that you're very familiar with, and maybe have had genetic testing yourself, or if you're totally new to this topic. I hope that our discussion today will be valuable for each of you. And please feel free to write questions in the chat of this Zoom, and we'll also have a few minutes at the end of this lecture for a Q&A. Just to give you a roadmap of this lecture, we'll start with some basics on genetic counseling and cancer genetics, go through a few brief examples of hereditary cancer syndromes or the conditions that we can test for, and how genetic testing can be helpful before finishing with a few practical considerations and other frequently asked questions. Genetic counselors are a type of healthcare provider with specific expertise in medical genetics and counseling, and we provide information about genetics, what we can test for, how these conditions are passed down in families, and talk about the risks and benefits of all of this. We also help people interpret genetic test results and help people make informed decisions based on that information. I specialize in cancer genetics, so that's where we'll focus today, but there are many other specialties within genetic counseling. And although we have specialized training, usually a master's in genetic counseling, we're not medical doctors, so we're not diagnosing or treating cancer. Instead, our work is really focused on helping people and their families understand hereditary cancer risk and make informed decisions based on this. This may be familiar if any of you have seen a genetic counselor before, but just to provide some background, usually at a first visit, I have a conversation where we review that person's medical and family history of cancer. And this is really important so that I can provide a good assessment of whether hereditary cause is likely or not, and so that person can have appropriate testing. We then talk more about the type of risk information that we can learn from genetic testing and what they could actually do with that information. We also cover specific testing options as well as the risks and benefits of each of these. Sometimes people come into this visit also already having had genetic testing either recently or many years ago, and this is also something that we can discuss and review and really assess the meaning of. If someone reaches the end of this first conversation and they want to do genetic testing, we also order this and can get results back in 3 to 4 weeks. And I want to emphasize the if here. Having a genetic counseling appointment does not mean that that person has to get genetic testing, and someone can absolutely have this visit to learn more, even if they're really not sure if they want any testing at all. If someone is doing genetic testing, I usually meet with them during a scheduled visit and we discuss all that this result means for them, their family, and any next steps after the visit. Any questions before we get into cancer genetics? We know that ultimately a relatively small proportion of all cancers are actually genetic. So most cancer, around 70%, is actually what we call sporadic. These are cancers that happen by chance and due to aging, and also just being human, although of course other lifestyle and environmental risk factors can also contribute to this category. Often people think first of cancers with environmental influences here, But we know that aging itself is also a risk factor for cancer, and that no environmental risk factor like smoking, for example, is actually needed to develop cancer. About 5 to 10% of all cancers are hereditary or genetic, meaning that there's a genetic mutation being passed down through a family from parent to child that's leading to higher cancer risk. For some types of cancers, though, the percentage with a hereditary cause is even higher than this 5 to 10%. There's some more specific red flags that can make us more concerned about a hereditary cause for cancer, which I'll talk a little bit more about in a moment. Another 15 to 20% of cancer is familial, and these families often look like families in the hereditary category. So we may see a clustering of cancers within a family, but in this case, there's no genetic cause found. This may be because of a combination of some smaller genetic and other shared lifestyle or environmental risk factors. For example, a family where multiple relatives have had different types of skin cancers, but they all had a lot of very significant sun exposure together might fit into this category. There are a lot of different clues that might suggest that a hereditary or genetic cause for cancer is likely, especially multiple cancers in the same side of the family. These could be the same type of cancer, or cancers that are related or that have shared genetic causes, like breast and ovarian cancer. Or we may see one person who's had multiple cancers, like bilateral breast cancer. Young cancers, or those that are diagnosed before age 50, can also be a sign of hereditary cancer. Although for certain types of cancers, this is not quite as relevant. For example, cervical cancer is common in younger women and is not usually a sign of hereditary cancer. There are some other rare cancers like ovarian cancer, male breast cancer, and triple negative breast cancer that can also be more concerning by themselves, even in people over 50 who don't have other family history. Ancestry can also play a role, as some populations, like people with Ashkenazi Jewish ancestry, are more likely to carry mutations in certain genes related to cancer risk. And this is by no means an exhaustive list, so there are definitely other rarer and more specific signs of hereditary cancer. So if these signs don't fit you or your family, but you still have questions about whether genetic testing would be helpful with your history, I'd always recommend exploring this more with a genetic counselor. Before we get into a few examples, I wanted to talk briefly about cancer genetics. So in all of our bodies, we have trillions of cells, and in these cells, we have our genetic information, or DNA. This is split into smaller pieces called genes, and each gene has its own job in our bodies. Some of these genes control things like hair color and eye color, but we also have genes that help protect us against developing cancer. So when we actually talk about doing genetic testing related to cancer risk, we're actually looking in cancer protection genes for mutations that can make them not work correctly and not protect us as well against cancer. So we all have copies of these cancer protection genes, but it matters if somebody has healthy copies or if they might have a copy with a mutation. And we have 2 copies of every gene, one from each of our parents. And these are usually like 2 healthy layers of protection or defense against cancer when we're talking about these cancer protection genes. If someone has a mutation in one of these genes, this puts them at higher risk of developing cancer, and they may also be at risk to develop cancer at an earlier age, but this usually does not mean that this person is definitely going to get cancer. And because we have 2 copies of every gene, when someone has one of these mutations, that means that if they have children, there's a 50% chance for each child to inherit that copy with the mutation and then have higher cancer risk. But there's also a 50% chance for each child to inherit the healthy copy of that gene and not have higher cancer risk. And most hereditary cancer conditions that we test for are passed on this way. I also wanted to highlight that we might see these cancer risks appearing differently in males and females, but the mutations are inherited in the exact same way between males and females. So for example, a patient who is male could carry a genetic risk factor for ovarian cancer. And of course, we never see that person develop ovarian cancer since they don't have ovaries, but he could pass that mutation on to a daughter who could then have a higher risk to develop ovarian cancer. Another distinction that I want to draw that might be relevant if any of you have had genetic testing on a tumor or cancer itself is the difference between what we call somatic and germline changes in our DNA. So somatic DNA changes are acquired over a person's life in single cells, and these can lead to the development of cancer. However, these are not inherited from someone's parents, so they're not a risk factor or inherited cause for cancer, and they also cannot be passed down to children. And so for some types of cancers, it might be common to have genetic testing on the cancer itself, or what we call somatic genetic testing, to look for specific mutations in cancer that could potentially impact someone's treatment. In contrast, germline DNA changes are present in every cell of the body in normal tissues and in tumors or cancer, including egg and sperm cells, so they can be inherited from parents and passed on to children. These are the types of genetic changes that we can look for with hereditary cancer genetic testing. And this is what we were just talking about as one line of defense down against cancer. So something that can increase a person's risk of developing cancer and potentially provide a genetic explanation. I have two examples to help illustrate this a bit more. This is just an example of the types of family trees or pedigrees that I'll be showing. Squares usually represent males, circles usually represent females, and this is basically a couple and their two children, a son and daughter. And while all of these three are realistic and really common types of family histories that I see, for my patients' privacies, these are all family histories that I created myself. So in this family, we see a grandmother with endometrial cancer at age 45 and a father, her son, who had colon cancer when he was 40. And then on the other side of the family, we see a grandmother with lung cancer at age 70 and a history of smoking. Does anybody have a guess or want to type in the chat which family member they think could consider genetic testing?
Maybe both.
Yeah, so good answer. So in this family history, really the most helpful or informative person to test is actually going to be the son who had colon cancer when he was 40. Of course, the person on the other side of the family history who had lung cancer, could always consider that, although we know that most lung cancers are sporadic, especially in sort of this context of another risk factor for lung cancer. And so the reason that he would be the most informative person to test, this person that's had colon cancer, is because we're always most likely to find a genetic cause for cancer in a person that has either had cancer themselves or is most closely related to the person with the sort of concerning history. And if he does genetic testing and a genetic cause is found, then his sister and his children know exactly what they're at risk for and what they should consider testing for. And if his testing is negative, then his children don't need genetic testing related to his history. And so even though these are two different types of cancers, colon and endometrial cancer, we saw them, together in two family members and at young ages, and these are types of cancers that have shared or common genetic causes that may explain both of those types of cancers. So because of this, he is really the most helpful person in the family to have testing, and he meets our national criteria to qualify for genetic testing. If for any reason this person wouldn't want to do testing, then it would be reasonable for his sister and his children to consider genetic testing, but there are just some limitations in how we might understand their results, especially if their testing is negative, because in that scenario, we're not sure if there is a genetic cause that they didn't inherit, or if there's not any genetic cause to be found in this family. Here's another example of a family, and here we see two people with skin cancer, although both with a lot of sun exposure, and one person with breast cancer at a later age. And so in this family, there's actually an overall pretty low chance of a genetic cause. So these cancers were all diagnosed at later ages, and although we do see two different types of skin cancers, they both occurred with another really significant risk factor, and we're not seeing, one person with multiple melanomas, for example, or multiple people in the family with melanoma, or certain things that may make us more concerned about a genetic cause. And while we do know that about 5 to 10% of breast cancer is genetic, the chance of finding a genetic cause in a family with one case of breast cancer at a later age is going to be smaller. So technically, nobody in this family meets criteria, our national criteria for genetic testing. And people in this family could certainly see a genetic counselor and consider the option to pursuing genetic testing. This is something that we usually offer even if someone doesn't meet criteria or qualify for testing. But the chance of finding a genetic cause is probably going to be relatively small. I know what we've talked about so far may seem a little bit abstract, so I'm going to go through a few examples of hereditary cancer syndromes, or the types of conditions we can test for in cancer genetics. BRCA1 and BRCA2 are two genes that are some of the most common genetic causes for hereditary breast and ovarian cancer. So these may be familiar genes. 1 in 400 people across the world carry a mutation in one of these two genes. And as you can see, people who have a mutation in one of these genes have a much higher risk of developing breast cancer, ovarian cancer, prostate, male breast, and pancreatic cancer. And BRCA2 has also been linked with melanoma risk. Lynch syndrome is another common hereditary cancer syndrome and is caused by mutations in one of 5 genes noted in the top right. And this condition is the most common hereditary or genetic cause for colorectal cancer. And about 1 in 300 people across the world have Lynch syndrome. And this is something that puts them at a higher risk to develop colorectal, endometrial or uterine, gastric, and ovarian cancer. And we can also see higher risks for cancers of the small intestine, parts of the kidney and bladder, and pancreas, as well as potentially brain and skin cancer. BRCA1 and 2 and Lynch syndrome are only a few of the many hereditary causes for cancer that we know of. And as you can see, some of these hereditary causes can increase cancer risk really dramatically over the risk for these cancers in the general population or for someone who is average risk. This chart is showing some of the highest risks that we can see across many different genetic causes, but there are also some genetic causes for cancer that we know are not high risk, so they only have a slightly increased risk of developing cancer related to that cause. On the right, this is just a table that's showing different genes and the syndrome or condition that they cause, and then all the different types of cancers that we see higher risk for with that condition. And you can see that a lot of these conditions are associated with a higher risk of more than just one type of cancer. And so when this testing is done, we can potentially uncover risks for types of cancer, a type of cancer that we have never seen in somebody's family. Another potential with this testing is that we could discover a moderate risk mutation. So what I just referenced a few moments ago, that not all of these genes are very high risk. So BRCA1 and 2, that first example, we can see breast cancer risk that's up to 85% over someone's life. But there are a few genes that are also associated with breast cancer where their lifetime risk is more like 20 to 30%. And as a result, these moderate risk genes may not fully explain someone's family history, especially if they have a really significant family history or a lot of very young or early cancer diagnoses. And the genes that we've discussed so far that I've mentioned already are genes that we have clear risk information for. So those charts showing us exactly how high the risk is, and we have management guidelines telling someone what to do if they have a mutation in that gene. But there are also options where someone can have genetic testing that includes genes with more limited information, which we call preliminary evidence genes. These are genes that have an emerging link to cancer risk, but usually unclear risk estimates and no guidelines telling someone to do something differently right now based on their result. We've talked a lot about the risks that we can find with this testing, but next we'll discuss what we can actually do with some of this information. Most of the genetic causes for cancer that we can find involve some type of enhanced screening. This might mean doing earlier screenings, like someone starting colonoscopies or breast cancer screening with breast MRIs in their 20s or their 30s. This could also involve shorter intervals or time periods between screenings, like having a colonoscopy every 1 to 2 years instead of every 10 years, or someone having prostate cancer screening every year instead of every other year. This could also mean using more advanced screening tools, so breast MRIs to screen for breast cancer, or advanced types of pancreatic imaging to screen for pancreatic cancer. And often finding a genetic cause for cancer involves many or all of the above in terms of enhancing screening. And the goal with these tactics is really to catch cancer early when it's most treatable. We also have methods that can actually reduce or eliminate cancer risk. These can include medications like tamoxifen, which can reduce breast cancer risk, and aspirin, which might be taken by someone with Lynch syndrome to reduce colorectal cancer risk. We also have options for preventative or prophylactic surgeries, like mastectomies to remove the breast, hysterectomy to remove the uterus, and salpingo-oophorectomy to remove the ovaries and the fallopian tubes, which can also be used to significantly lower someone's cancer risk. For some hereditary causes for cancer, these may be just one option to consider, but sometimes there is actually a recommendation for someone to have a surgery like this. So for people that have BRCA1 and BRCA2 mutations, there is a recommendation to remove the ovaries and fallopian tubes. And with these approaches, the goal is instead to prevent cancer entirely or substantially lower cancer risk. Sometimes genetic test results can also impact treatment for an existing cancer. For example, PARP inhibitors are a type of targeted cancer drug that might be used to treat ovarian, prostate, pancreatic, and certain types of breast cancer when there is a genetic cause. And more rarely, they can impact other cancer treatments. So there are a few very rare genetic causes for cancer that could lead to a recommendation to avoid radiation therapy, as we can potentially see higher cancer risk after radiation. Although again, these are pretty rare conditions that would lead to that sort of recommendation. And these results are also commonly used to help with surgical decision-making. For example, someone with breast cancer might be choosing between a smaller surgery, like a lumpectomy, or a bilateral mastectomy, removing both breasts, and have genetic testing to help really inform their risk of breast cancer in the future, which may help with some of that decision-making. For some people, this is also information that they're considering when family planning. There are technologies available where a person can undergo in vitro fertilization, or what's called IVF, to create embryos from egg and sperm from themselves and their partner, and then test those embryos for a mutation in a hereditary cancer gene. And that couple could choose to use embryos that did not inherit a specific mutation. Earlier, we just talked about sort of risk reducing surgeries like mastectomies or removing the ovaries, and especially for younger people that are considering these surgeries because of a genetic test result, this might be information that they use to make decisions about how and when to sort of grow their family. And most of the genes that we test for involve adult onset cancer risk for somebody who has one mutation in that gene, but some of these genes can also cause more serious childhood onset conditions when a person has two mutations in the same gene. And so because of that, many people who have mutations in these hereditary cancer genes, who are planning to have children in the future, are also recommended to have testing for their partner in order to find out whether their future children could be at risk for one of those childhood onset conditions. For many people, finding a genetic cause for cancer can also provide a clear answer for what they or their family members have been through and why someone may have developed cancer in the first place. The last way that I think genetic testing can be helpful, and that I think is an often overlooked benefit, is that it can also give reassurance to some family members. So on the right, it's just an example of a family history with a mother and a daughter that have had both breast cancer, and the daughter has also had ovarian cancer. So in this family, the mother and the daughter have genetic testing and are both found to have a mutation in the BRCA1 gene, which completely explains that family history of breast and ovarian cancer. The granddaughter then has genetic testing and does not carry the BRCA1 mutation. So she may have really otherwise gone through her life very concerned about her cancer risk because of her family history, maybe even had a lot of extra earlier breast cancer screening. But now, because of this result, we know that she's not at higher risk of cancer because of her family history. Now that we've talked about how someone could use this information, we can finish up with a few practical considerations and other frequently asked questions. And I saw before that there's at least one question in the chat, so we can also, we'll also definitely have time for a Q&A at the end. With cancer genetic testing, we can actually find 3 different types of results. The first is a positive result, meaning we find a mutation or a genetic cause for higher cancer risk. And in this case, we talk a lot about what we know about that risk, how we can manage them, and any next steps like specialists that someone should see. We can also find a negative test result, meaning we didn't find mutations in any of the genes that were tested. Someone might still qualify for extra screening based on their family history or other factors, so we still discuss what this result means with all of that context. The last type of result that we can find is a variant of uncertain significance, or a VUS, which is also basically a question mark result. This means that we found a genetic change or a variant, so like a spelling change in the DNA, that we don't have enough information to know whether it increases cancer risk or not. These types of results are very common, and we treat them as innocent until proven guilty. So in the meantime, this doesn't impact how we think about someone's risk, their screening. There's not a need for family members to be tested in most cases. And this is because we know that these types of results are much more likely to be classified or sorted into the negative category because we find out that this is benign or harmless variation. Less commonly, we find out that these are actually related to higher cancer risk, and they're resorted or upgraded into the positive category. So this is something where when I receive an updated result from a lab after I've had ordered genetic testing for someone, I share this update with my patients so that they're aware if there's a change in how this result is classified for them. Many people are now able to have genetic counseling appointments from their home with video visits or telehealth, but of course there's also an in-person option. And it is also possible to send a sample for genetic testing from home as well. Sometimes this might just be a saliva kit like the one on the right that someone just spits into, or could involve mobile phlebotomy, so a blood drawing service that's scheduled to come to someone's home to draw blood for genetic testing. And these are really, really great tools for anyone who may live far away from genetic counseling services or just find this to be more convenient. Another common question or concern that I hear a lot is about genetic discrimination. So we're all protected by a federal law called the Genetic Information Non-Discrimination Act, or GINA. So this is a federal law that applies to every state. And this law says that your health insurance is not allowed to discriminate based on genetic test results. And this includes private insurances, whether they're purchased, individually or through an employer, Medicare, Medicaid. And this means that health insurance companies are not allowed to raise rates, drop someone from coverage, or basically they're not allowed to treat this like a pre-existing condition. And there are a few rare exceptions like TRICARE, the Indian Health Service, Federal Employees Health Benefits Plans, although there are some similar protections for some of these situations as well. GINA also protects against genetic discrimination from employers that have at least 15 employees. GINA does not apply, though, to life insurance, long-term care insurance, disability insurance, and any other private specialty insurance. So this is usually most relevant if someone is getting or changing any policy, since that company could ask someone if they've had genetic testing and could deny them a policy or make them pay more for that policy based on their result. The website at the bottom right, GINA Help, also summarizes some information about this law. If any of you are interested in genetic counseling, it's also very easy to find a genetic counselor through the Find a Genetic Counselor tool provided by the National Society of Genetic Counselors. You can reach this tool by either scanning the QR code, which is on the right side of the screen, or copying down that blue link in the middle of the slide. And this tool lets you filter to only search for genetic counselors specializing in cancer genetics, and to search for either telehealth or in-person providers. And if you're searching for in-person, I would just recommend searching by zip code. And if anyone would like this link and doesn't have a chance to use the QR code, I can also post it in the chat if that's helpful. One of the other really common questions that I hear a lot about genetic testing, or common concern, is that it's going to be very, very costly. As part of any genetic counseling visit, I discuss whether insurance is likely to cover genetic testing based on someone's personal and family history information that we've collected. If insurance does not cover genetic testing, or if testing is just going to be expensive with someone's insurance, or if they don't have insurance at all, many of the labs that we would order testing from have a $250 self-pay option for genetic testing. And I understand that $250 may not be affordable for everyone. And in this case, many labs also have patient assistance programs based on income that can reduce the cost further, sometimes to $0. And someone may also qualify for a $0 out-of-pocket cost for genetic testing, depending on their specific type of insurance or family history. So these are things that we discuss as part of a genetic counseling visit to really set expectations for billing. And genetic testing used to be much more expensive. And so I would say for anyone that's interested in genetic testing but concerned about cost, I would always recommend seeing a genetic counselor to discuss this more, just before, assuming that it wouldn't be affordable for you. I also often hear questions about whether someone who has already had genetic testing in the past needs more. Depending on the type of test that someone had, updated testing may be really, really helpful. So a genetic counselor can also review previous genetic testing and really assess if more testing would be helpful. They might offer updated testing technologies that could potentially find mutations in genes that someone already tested negative for, or testing for additional genes. And so just to give one example, someone who had genetic testing in 2005 may have just had 2 genes tested, BRCA1 and BRCA2. But if you compare this to on the right, I know it's really tiny, but each of those columns is a different type of genetic test based on specific types of cancer. And those 2 very long blue columns on the right are basically lists of some more comprehensive cancer panels. And so you can see that these 2 genes make up a really, really small sort of sliver of all of the genes that we can look at now with genetic testing. And as some direct consumer tests like 23andMe have become very, very popular, more questions have also come up about how this test is different from the type of genetic testing that someone would have ordered with a genetic counselor. So this screenshot is from 23andMe's website and shows the 5 genes related to hereditary, or the 4 genes related to hereditary cancer that are included sometimes in testing. Although for some of these genes, they're only looking at a handful or only one specific variant or spelling change in that gene. So this means that 23andMe is only looking at a few locations in these genes, so they wouldn't find every mutation in that gene. So on top, this is just an example. Each of those red flags is basically a mutation in the BRCA2 gene. And 23andMe may only look at one of those positions and only detect a mutation if it's that one specific mutation that they're looking for, and miss those other 3 mutations if any of them were present. And so on the bottom, you can see in comparison what clinical genetic testing can look at. So we can look across the entire gene and in other genes. And this type of test would pick up, all 4 of those sort of examples of mutations in the BRCA2 gene. 23andMe even outlines this really nicely on their website by pointing out that this is not a comprehensive cancer screening test. For example, there have been more than 4,000 risk variants found in the BRCA1 and 2 genes, but their updated test looks for 44 of these variants. Thank you so much for all of your time this afternoon. I'd really love to hear from you all. I'll get started with some of those questions in the chat, but feel free to unmute yourselves to tell us your questions and also post other questions in the chat. And this is my email address. So feel free to reach out if there are other questions that you might not feel comfortable sharing within the group. Just open up the chat. Okay. Okay, I saw you raise your hand, Deborah. I'll just start with Sarah Lee's question about what is a good response to someone who says to you that you got cancer because of, example, lifestyle factor like stress, artificial sweetener, etc. I would say, really with some of these like environmental or lifestyle risk factors, it's really hard to, with certainty, pin down some of these things as the cause for cancer. There are some exceptions like, smoking and lung cancer or a lot of sun exposure and skin cancer. But a lot of like those factors that you gave as examples like stress or artificial sweetener, we don't necessarily have a lot of very clear data to say, this is, directly causing this type of cancer. And I think the other kind of response to this is we know that cancer doesn't need a specific risk factor, whether that's lifestyle or environment, to develop that. So someone can truly do everything right with regards to their environment and their lifestyle. And we all just still have that risk of developing cancer just as human beings. I think I saw that you had raised your hand. Deborah, do you have a question?
Yeah, that's more of a comment. I had breast cancer and ovarian cancer last year. Fortunately, I'm in remission. I was BRCA negative. My mom had the exact same ovarian cancer, same pathology. And my oncologist recommended to my sister and my daughter to get prophylactic oophorectomy, salpingectomy, which my sister just had last week. So she's recovering. And the only genetic, I had the testing genetic, my kids did. Only mutation that they found was APT, which is colon cancer. So it's helpful, but I think screening, I'm an RN, retired. Screening is the most important thing, more than anything else. Mammograms, colonoscopies. And thank you so much for your presentation.
Of course, yeah, and thank you so much for sharing about your experience. I'm really glad to hear that you're doing well now. I think that's a great example of sometimes there are personal histories or family histories that look really strong, where we think we're going to find a genetic cause, and we're not able to find one. So where a negative genetic test result doesn't mean everyone in the family disregard cancer screening or don't worry about this at all, because sometimes there are family histories that are still really strong where we don't find a cause, where it's still very important to have a personalized discussion, like it sounds like your sister has had, about what the risk is at this point with the family history and how they might address that.
Yeah.
I think I saw Sarah, you raised your hand.
Yes, please. May I ask a follow-up question to what you were describing before as a common question on the return visit for additional counseling if you already had prior counseling? So is it possible before you return for that second visit to ask them if there is, in fact, any additional genetic counseling or testing that has come about since your initial visit, rather than going in for the second visit and then actually not having much new info to discuss?
Yeah.
Is that
No,
possible?
great question. So not having a follow-up visit to get told nothing new, nothing for us to talk about. Yeah. So what I always recommend to my patients that might be interested in thinking about updated testing in the future, or even people that have a positive result, I always recommend that they check in with me for people who have a mutation every year or two to learn, any updates about the condition. And for someone who, may have had genetic testing and not found a cause, who's interested in updated testing, I usually say to reach out to me every 3 to 5 years, and that doesn't have to be a scheduled follow-up for either of those scenarios. I usually just have people reach out to me, by phone or email. And of course, like every genetic counselor sort of setup is different, but I do that so that someone doesn't have a follow-up visit, and kind of go through all the effort of that without having something, valuable or new that I can share with them.
Okay,
I think
thank you.
really great question.
Okay, thank you very much.
Any other questions? Either, feel free to post in the chat or raise your hand if you'd like to ask a question.
Are there certification requirements for testing labs?
Yeah, so the labs that we send testing to are usually CLIA certified. So these are labs that are different from what people may be familiar with, like direct to consumer testing through Ancestry and 23andMe, which sort of have their sort of pros and cons. So these labs do have specific certifications and a lot of experience in clinical testing when we're actually sending genetic testing for someone to that lab.
Okay, that looks like Deborah has a question. Deborah, you're on mute.
No, I'm sorry. I didn't mean to raise my hand again, but
Oh, it's okay. Just want to make sure.
yeah, no, I had BRCA negative years ago test, and then I got tested again. And I still think for me, every time I have had colonoscopies, I'd had polyps. And I could tell you as a nurse and my experience, those are removing precancerous growths usually. That's one of the most important screens everyone should get besides mammograms for women, I believe.
Yeah, I think that that's a great example of colonoscopy being like one of those few screening tests that can actually reduce risk, because if we're able to remove those precancerous polyps before they turn into cancer, we may also help someone avoid actually developing colorectal cancer. So, a really kind of unique and special benefit in that way. And okay, I see two more questions. If I'm familiar with the breast cancer index test, is there a genetic component that they look for in that test? So this is something that I'm not necessarily familiar with. From just kind of looking it up right now, I think that it sounds like this is a test, correct me if I'm wrong, but is more related to determining how helpful certain treatments will be for breast cancer. And there are a lot of different tests like that. Sometimes they do look at the genetics of the cancer tumor itself. So what I talked about earlier as like somatic genetic testing. Occasionally with some types of somatic genetic testing, we can pick up a mutation that's inherited, but these tests, usually the purpose is not to find hereditary causes for cancer or to find inherited mutations. So I would say for many of these, they're either not looking at that type of information, or they're looking at it in an incomplete way where someone would still usually benefit from having actual genetic testing on a blood or saliva sample to look for hereditary causes for cancer.
Excuse me, I think that it's really for how long you take something like an astrozole, because that's what it is.
Yeah.
Like usually breast cancer, you take it for 5 years is the standard.
Yeah.
Right.
Oh, go ahead.
It's, from what little I know of it, is that it's to help determine if the anti-estrogen drug should be continued for a longer period of time or not. So I was just wondering what exactly they're testing on the tumor. They take the original biopsy and use that, but I don't know what they're looking for or how that helps them, or what tells them to what the answer is to that question. So that's what I was just wondering.
Yeah, no, very, very good question. So, even if they're looking at genetic components of the cancer or tumor itself, which, is a possibility with some of those types of testing that might be used to direct treatment, it's usually not going to be the best test to find these genetic causes, or it might not look at them at all. And so that's where, having genetic testing like this, it can be helpful. And that type of testing might not give us that type of information.
Thank you.
And I also see another question from Judy. How common is genetic testing done for someone under age 40? Thank you. Sometimes it's hard to convince younger kids with busy working life. Yeah, so this testing is something that we do see quite a few people who are much younger, who are in their 20s or 30s or 40s, who have never had cancer, that are maybe concerned about cancer in their family. And so I would say this is, definitely a test that someone can take if they, are a young adult, even if they've not had cancer, and is actually a pretty common group of patients that we see. So of course, it can sometimes be more difficult for someone to fit this in with their life if they're, young and very busy. But a lot of the conditions that we test for, someone could have screening starting in, their 20s or their 30s. So it is certainly possible for someone in that age category to find out a result that would really change their screening in the immediate future. And I see second question, how often is false negative results? So this is something that's extremely, extremely uncommon. Really, a lot of the labs, they quote specific numbers on how sensitive their test is, so how good it is at finding these mutations in these genes. And so for a lot of the tests that we would order, the sensitivity or the chance of finding the mutations that we know of in that gene is more than 99.9%. of those mutations should be detected by that test of these sort of detectable mutations. So those types of, like a false negative result is something that is very, very uncommon, thankfully. Any other questions? Okay. What lab to use, recommend. So there are really a lot of different genetic testing labs. There's not like a single one that I would recommend as like the lab to have testing. And genetic counselors are very familiar with what type of lab might be best for someone in terms of, their specific insurance, what types of genes would be helpful to look at based on that person's personal or family history. So those are some of the components that we think about when choosing a specific lab to send testing to. So usually we do have, at least a few good options of different genetic testing labs that we might send testing to. Any other questions, either like in the chat or anyone that wants to speak up with their question? Well, thank you so much to all of you for taking the time to come to this lecture. I really, really appreciate it. It's been great to speak